Hello friends. So today I'll be talking on this surgical soft tissue complications and urgencies. So it's a very ultra basic overview of the soft tissue infections, which I had to do in one of the courses on Sunday recently. So it's a very ultra basic overview for all the new trainees, just to have conceptual understanding on approach to this. So I'll do this as a part of a case scenario. So the objectives of this talk is to identify a normal healing wound and recognize wound dehiscence and infections and recognize and manage necrotizing soft tissue infections, which we see fairly often in ICU. We see necrotizing fasciitis and necrotizing soft tissue infection is not uncommon in ICU. So it is important we recognize this entity and recognize and manage compartment syndrome. So these are the objectives of the day. So we start with a case scenario. A 58-year-old man sustained trauma to his leg while working on his field. He presented with a painful open wound on the inferior portion of his leg and underwent fixation of a tibial fracture. So on day two post-op, he had worsening pain and increasing skin edema along the surgical side. So this is in the setting of a surgery, he develops edema, swelling, and pain. And the erythema increases and he has been having fever the next day. So the questions that would automatically come in a patient who has undergone a surgery for the tibial fracture, developing some inflammatory signs at the site of injury. So what distinguishes a normal? Is it a normal extension of the post-operative wound or a complicated wound? And what are the critical first steps in managing a wound complication? So these are the two questions that would arise. So here the key aspect is to determine whether it is a clean wound or an infected wound. So we need to have some understanding what is the difference between normal versus complicated post-operative wound. So this, when you look at it, it looks as a uh, non-complicated neat wound. We call it as a clean wound when the wound looks clean, when it is dry and the edges are intact and and it is easy to approximate the edges. And they should not. The key important aspect to say it is a clean wound is when there is no serosanguinous discharge or there is no purulent discharge. So the discharge should be absent. So that possibly convinces us that it is a clean one. So it should be dried, clean, approximation of the wound should be possible, it should be intact, and there should not be serosanguinous discharge. In contrast to this, and there should not be any purulent sort of a exudate there. In contrast to this, a infected wound is very obvious for most intensivists. It looks something like this. So there is an HR formation as you see. Then the key aspect is there's a lot of erythema and there'll be a lot of pain. There'll be a progressive increase in the pain in any infected wound. There'll be a lot of swelling. So there will be erythema, there will be swelling, and there will be purulent discharge, and there will be some HR formation. So this is the sort of a differentiating between the clean wound and the infected wound. So talk a bit about how do we classify surgical wound infections at that site of incision. So suppose you have an abdominal incision. So the surgical site infection is divided into three aspects. We call it a superficial incisional infection, where the infection is limited to only the suture line, or we call it a deep incisional wound infection when there is subcutaneous planes and the deeper structures below the incision that are affected. Then we have the viscous or the any cavity infections where abdominal cavity or any other cavity or the space deep inside, deep structures are involved and there is infection. We call it as a deep-seated infection. So superficial incisional infection, deep incisional infection, and viscera or the hollow viscous or the other cavities infection is the third variant of surgical wound infection. So when we talk about the risk of wound infection, so what are the features of a surgical wound that portends increasing risk for infection? So the type of surgery is very important to determine what is the risk of infection. So we'll talk about it briefly. And duration of surgery. So the longer the surgery, the greater is the risk of infection. So which is something that's why when we are doing a post-op takeover or handover, it is very prudent to ask what is the duration of surgery. So the longer the duration of surgery, the risk of infections are higher. and whether there was any contamination during surgery. Suppose there is a abdominal surgery and there is a spillage of the bowel content, then obviously there is increased contamination, risk of infection is more. Or if you are handling biliary duct, biliary tree, if there is a spillage of the biliary fluid, then obviously there is contamination, there is increased risk of infection. And when there is increased risk of infection, especially when we are dealing with an abdominal structure, then it portends an increased risk for infection. And many a times you would see when there is a lot of like perforated viscous surgery, they keep the wound open because there may be a need for re-exploration to clear the residual infection that may be present. So open wound is sometimes becomes necessary in these infections where there is a lot of contamination of any of these cavities where it is operated upon. So this is important for our ICU training. How do you classify wound infection? So this is something little important, although it is basic. So class one is it's a clean wound. I showed you clean wound is where there is no erythema, there is no serosanguinous discharge. It is a clean looking, dry, and approximation of the wound edges would happen. So that is straightforward, intuitive. So the second class is it is clean contaminated. So what do you understand by clean contaminated? So this typically happens when you're dealing with structures like biliary tree, because bilious fluid is meant to be sterile, but there can be some infection pre-existent which can lead to problems, or appendix, vagina, or oropharynx. So if any of the surgeries involving these structures can lead to clean contaminated wound. Class 3 is contaminated, where there is spillage of infective elements into the body spaces or perforated viscous, so on and so forth. Class 4 is very obvious, dirty infected wound, secondarily infected, and even perforated viscous with a lot of spillage also come in this dirty infected wound. So this is the typical classification of surgical wound infection. And the key aspect that delineates between class 3 and class 4 is class 3 there is contamination. Class 4 there is a lot of devitalized tissue. There is dead tissue which needs to be taken out. So devitalized tissue is a representative of dirty infected wounds, which is class 4. So now we'll talk a little bit on how the whole process of healing of surgical wounds. And this you may have studied from first year MBBS. Healing happens in three different ways. There is primary healing by primary intention, healing by secondary intention, and healing by tertiary intention. So healing by primary intention, what it means is there is no tissue loss. As you see, there is a good approximation of the wound, and primary suturing will help heal the wound. But in the healing by secondary intention, there is more of a gaping wound and there is a loss of tissue, and only the suturing can be done of the deeper planes, and the superficial plane has to heal by itself, and it takes a little longer time, and this is healing by secondary intention. So tertiary healing by tertiary intention, where there is a slow healing process that happens, and there is inability to do a suturing, and the wound takes long time to approximate, and there will be a scar formation with a scab also that will be formed in healing by tertiary intention. And these are the typical. So the ideal type of healing we would need is primary healing, and many a times, especially in the complicated abdominal surgery, secondary intention also many a times happens. A lot of gaping wounds with lot of devitalized tissue. Many a times it happens with tertiary healing where back dressings and long-term sort of a healing process has to happen. So what is the ideal wound healing? Ideal wound healing is obviously by primary intention. So there are certain prerequisites when we are talking about ideal wound dressing. So the ideal wound dressing is described as it should be moist, and there should not be a need for frequent change of the dressings when a dressing is made, and it should be impervious. So it should be impervious to any bacteria or any external source of infection, and it conforms to wound, and there is reduced pain with this dressing, whatever is pushed, and this dressing should be cost effective and should be lower cost. So these are the typical ideal sort of a characteristics of the dressing that one would look for. There's something called occlusive dressing where you completely close the wound. Obviously, there won't be access to see the wound. Where you are sure that wound healing happens well with primary intention. It is a clean wound, so you're confident that wound healing happens effectively, and epithelialization and the healing would happen in 24 to 48 hours. In this, we do this occlusive sort of a dressing where there is no ability to keep relooking into the wound and change it. And there is a good sort of a perception that healing would happen by primary intention. So now we'll talk a little bit on surgical soft tissue complications. So it is very prudent and important when any wound is there post-surgical that periodic examination of the wound by removing the dressings are terribly important to see if there is any signs or signals towards secondary infection. And it is important to keep looking at the suture lines to see if there is any erythema, there is any induration, any swelling, any serosanguinous discharge, or any tenderness, which all point out towards possible underlying infection. So so taking out the, I'm sure most of the intensive care friends who are listening to this, any surgical patient who comes to ICU, first thing in the morning, you would see the surgeons coming, opening the wound, looking at the wound site, and the first thing they would tell is the wound looks very clean, and this is not the source of infection, especially in patients who has ongoing fever or some sort of a undercurrent with regards to some sepsis, indolent sepsis. So you would always be worried whether it is skin and soft tissue, and this is something that is done as a ritual by the surgical teams. They would keep looking at the wound. So this is something very important in any patient who has undergone surgery to keep looking at the surgical site, removing the dressings, and keep looking at the dressings to see whether there is any infection setting in. Why we do that? Because we also look for wound dehiscence. So we need to understand what really happens in wound dehiscence. This is just a pictorial representation of how the dehiscence looks. So there is a gaping of the wound, and there is a non-approximation of the skin, fascia, and even the muscle planes when the dehiscence happens. So there is separation of the skin would be a simple dehiscence, but there can be a disruption of the fat planes, the facial planes, and the muscle planes at the multiple levels, and sometimes even at the facial plane. So this is a deep sort of a wound dehiscence that can happen. And there are certain risk factors for dehiscence. So age, frailty, malnutrition, obesity is one of the important risk factor for wound dehiscence. And someone who is on steroids, we understand the wound healings are delayed. So that also becomes a risk for dehiscence. And someone with immunocompromised state also is a risk, and someone with underlying sepsis. So these are some of the defined risk factors for the wound dehiscence that can happen in a surgical patient. And we see this very often in ICU, dehiscence happening, especially in a deconditioned patient, and obesity is a risk factor, and someone who's on steroids, so on and so forth. And what about wound drainage? So if there is a new serosanguinous discharge from the suture line, then it may be necessary that surgical consult is sought, and exploring this wound to remove the collection under the suture line may become important. So it may be, if there is any new serosanguinous discharge, it is important to look for, it may be simple subcutaneous fluid collection, or it may be indicator of something sinister that is happening deep within, which may eventually lead to wound dehiscence. So it needs exploration, and surgical consult has to be sought when there is any new serosanguinous discharge from the suture line. It may be simple subcutaneous, or it may be a marker of underlying deep-seated infections, and surgical consult has to be sought. And wound dehiscence, decreasing the risk. How do we decrease the risk of wound dehiscence? Especially in abdominal surgery, efforts have to be taken to reduce the risk of ileus, because when there is ileus, there is abdominal distension. Obviously, the pressure increases, and it can be perpetuate the risk for wound dehiscence. And nasogastric compression with a Ryle's tube also goes a long way decompressing the stomach. And some abdominal binder can be put in to prevent wound dehiscence. And I'm sure many of the ICU trainees where there are post-surgical patients, you would see they would have put a tight abdominal binder to prevent wound dehiscence. And treatment in case of dehiscence, if it is a simple dehiscence, skin packing is good enough. But if it is deeper, surgical intervention may be needed to fix the dehiscence. So sometimes you would have seen in a perforated viscous surgery, etc., or a Whipple surgery or a pancreatitis surgery, there can be complete evisceration of so the intestines coming out when there is a major sort of a bowel surgery that may happen. So sometimes you see this sort of a situation where all the intestines would have come out, or polytrauma patient where the whole. So what do we do in this situation? So obviously they have to be packed with a moist gauze piece from intensive care perspective. Obviously, you have to call the surgeons, and surgical consult has to be brought in because pushing the bowel contents inside on the bedside is not a solution. They usually take them to theater, and exploration and correction of this evisceration has to be done from the surgical standpoint. And wound dehiscence of the sternal wounds can be very notorious, and they portend a very bad sort of a morbidity indication. So if you have a wound dehiscence of this nature in the sternum, almost always they need debridement because it almost always is secondary to infection, which leads to the dehiscence of the sternal. And most of the listeners would know how problematic can be the sternal dehiscence once it happens. It leads to a huge morbidity and mortality risk. And surgical debridement is the way to address some of these sternal dehiscence. So very quickly, we'll talk about necrotizing soft tissue infections, which we see very commonly in ICU. So necrotizing fasciitis of this nature portends a very sinister sort of an outcome in our ICU, and we see many of these. So what you typically see is a bulla formation with a lot of devitalized tissue, and typically caused by Streptococcus and Staphylococcus species. So you see cellulitis, you'll see induration, you'll see bullae formation, all in one area, and it can be very painful. And it is typically caused by Streptococcus species, and severe pain is the hallmark of necrotizing fasciitis. And most of them, this necrotizing fasciitis is not a local problem. They come with a septic shock, with multi-organ dysfunction, and the risk of mortality remains very high. So how do we sort of classify? So it has been very clearly noted this is a surgical emergency. When you have necrotizing fasciitis in ICU, there's no business for you to sit on the patient. You need to notify the surgeons, and it is a surgical emergency needing intervention. And it is shown delay in the surgical intervention is directly proportional to the increase in the risk of death in these patients. The risk factors for necrotizing fasciitis is obviously, it is associated with increased mortality. Age more than 60 years is a risk factor for increased mortality. The greater the area of involvement of any leg or extending to abdomen, portends increased risk for death. And someone coming with hypotension, someone coming with lactic acidosis, someone coming with MODS, which is all very intuitive for all our intensive care friends, portends higher risk for mortality. Or someone who is immunocompromised, someone who's on chemotherapy coming with necrotizing fasciitis, or bad non-compliant diabetes with CKD coming with necrotizing, all these portend bad prognosis with poor outcome. So those are the risk factors. And most important, how do we classify necrotizing fasciitis and WBC more than 10K? So necrotizing, how do we classify? There are three classifications. Again, this I think is important for intensive care. There is type 1 is the most commonest. 85 to 90% of necrotizing fasciitis is type 1, which is caused by either gram positive or negative with anaerobes. So it is a polymicrobial. Either it can be gram positive, gram negative, anaerobes, combination of these are the typical sort of necrotizing fasciitis that we see. And type 2 is the second commonest, where it is predominantly caused by gram positive, either streptococcus along with staphylococcus. Combination is what we see as the second most common. The rare one, which is unlikely, is monomicrobial. So this is very important for us to appreciate. Commonest one is polymicrobial. It is gram positive, gram negative anaerobes, and type 2 is Streptococcus and Staphylococcus, and type 3 is monomicrobial. So which is very, so this is something which I think intensive care friends need to understand, that monomicrobial is a misnomer in necrotizing soft tissue infection. So it can be either gram positive, gram negative, and even bacillus and clostridium species also come in this. So this is the classification of necrotizing soft tissue. So just last couple of slides about compartments. So we look into the case study 2. 63-year-old man fell and was found 24 hours later with a cervical spine fracture. After cervical discectomy and fusion, he was transferred to ICU, intubated with a right radial artery. On post-operative day 0, his right hand becomes swollen. The hand was elevated and compressions were applied. The edema worsened and the arterial line was removed, but the edema began to affect the distal forearm and the area began to harden. So as you see, this is a complication after putting an arterial line. Patient has developed a very tense sort of a upper limb. So which is typically a case of compartment. So what are the possible etiologies? Compartment syndrome is not uncommon that we see in ICU. So typically compartment syndrome happens in the extremities of we are not talking about abdominal compartment, we're talking about compartment syndrome of the extremities in the muscle plane. So it can be broadly divided into traumatic and non-traumatic compartment syndrome. So common sites are the anterior part of the leg, forearms, thighs, hands, arm, and foot. So these are the common sites where compartment syndrome of the extremities has been defined. And the features of compartment syndrome is typically defined as six P's. Six P's. So you can remember that. So they can have paralysis because there is increased pressure. There is a neurological deformity. There will be compression of the nerves, and they will have paralysis, and they'll have paresthesia because sensory and motor aspect will be lost. Severe pain is a common pallor because there is hypoperfusion of that limb. There is pulselessness and poikilothermia. So the six P's is what is defined as typical features of compartment syndrome. And because of compartment syndrome, they can have rhabdomyolysis also. And initially, the pain will be more, but with the progression, the pain of compartments tends to come down because the nerve endings will get desensitized and there will be reduced pain once it extends. So initially, there will be a lot of pain and then pain comes down. But in necrotizing fasciitis, the pain will be progressively increasing with worsening. And rhabdomyolysis is also something that happens in compartment syndrome. So that's the brief overview about the skin and soft tissue infections, a bit on compartment syndrome, wound dehiscence, and very ultra basic approach to how we address this. So compartment syndrome management is surgical emergency, and you need to get in surgeon to decompress and do the surgical relief of the pressure. And this has to be done within 6 to 8 hours. Otherwise, it can lead to permanent loss of that extremity because of the compromise of the vessels and the nerves. So that's it, folks. So that's the overview of the skin and soft tissue infections, wound management, compartment syndrome, the dressing, and the wound adhesion. So thank you one and all. So I request all of you to submit your valuable work to our journal, Journal of Acute Care, which comes out every 3 months. And visit my website, www.drpradeeprangappa.com, to rehear to this. So thank you one and all.